This is really an everyday problem in medical practice and breast cancer care. And it's really a multiple times per day problem. And it's something that we've sort of always had in the back of our mind. We're a little wishy-washy about what we tell patients. And so we've wanted to be a little more precise about who really benefits and where the benefit comes from with endocrine treatment for patients who have ductal carcinoma in situ, who've had breast conservation surgery. The mainstay all along has been radiation treatment for these patients. That's sort of the standard treatment, although we know that most patients don't really need it. We haven't had a good way to figure out who needs radiation and who doesn't. The classic traditional factors that we look at, things like age of the patient and grade of the lesion and size of the lesion, those sorts of things, over and over and over and over again have proven not to really select patients who do or don't have a radiation treatment benefit. And still we've tried and tried using those old school parameters. The most recent was the RTOG 9804 study, really selecting patients who looked like they had lower grade tumors, better margins. None of those things selected patients who did not have a radiation benefit, and none of those things really selected patients who long-term didn't have an unacceptable recurrence rate. So the company that we worked with in this research project developed a 7-gene assay, and it's mixed 7 genes with 4 clinical factors. And it's been established now, validated recently in the SWE DCIS prospective randomized controlled trial, validated in historical cohorts before that. So that assay was validated, and then very recently, a second assay, a second algorithm using similar factors, looking at KRAS pathway activation, showed that a subset of the folks who had an elevated risk, a subset of those folks had very elevated risk and had a radiation treatment benefit, but even after radiation treatment had an unacceptable high risk for relapse. And so those patients were designated as residual risk type, so a subtype of the elevated risk. So basically this assay tells us who does and who doesn't benefit in a way we always hoped that the clinical parameters would. But it doesn't really rely on those old clinical parameters as much as the 7-gene component. So there are 3 classifications now: the low risk group, the elevated risk group, and then there's a subset of that elevated risk group that has this residual risk subtype. So that's what we looked at, those 3 designations. And then we looked at how do radiation treatment and endocrine treatment interact there. And it's very challenging to tease those 2 things out, because if you have 1 child, you can figure out who did it, right? If you have 2 children, it gets more complicated. And we're talking about radiation and endocrine treatment. And we know that in the low risk group designated by that assay, there's no benefit to radiation. The risk is very, very low, and you don't see a significant benefit to radiation. On the other hand, in the elevated risk group, there's a substantial benefit to radiation, much more than we ever saw when we just radiated everybody, which was about a 50% reduction. In this elevated risk group, when you've pulled out those low risk patients that don't have a benefit, in the elevated risk group, the radiation therapy benefit is about 70% reduction in recurrence risk. So we know that fact. The next question was, do we have enough patients? Do we have enough patients to look at to see whether endocrine treatment, and we need that information about endocrine treatment. And in fact, we looked at 4 very large cohorts using this new hypothesis, basically, about the residual risk subtype, but we also had endocrine treatment information. So we had those 2 pieces of information, and we saw, of course, that there was a big benefit to radiation therapy in the elevated risk group, and a big benefit in the residual risk subtype, although much higher risk after radiation anyway. And the bottom line here is that endocrine treatment appears to do something we've sort of known all along. It appears to reduce new primary breast cancers in patients who've had radiation treatment. And that's generally about a 3 or 4% reduction. And that shows up in the ipsilateral breast. In quadrants elsewhere, it reduces that new primary risk. And it also shows up in the contralateral breast, a reduction in new primary breast cancers. But in the patients who had radiation treatment, it doesn't seem to add anything. Interestingly, in the patients who did not have radiation, who were in that elevated risk group, it does seem to do something. It does seem to reduce their risk, although in general you'd want to treat those folks with radiation treatment. If you can't, then this is an idea, because it does seem to have a benefit in that group, patients in the elevated risk group who have not had radiation for one reason or another. Not much help in the residual risk subtype, but in that elevated risk group, that's the group where we see it. And it really seems to break down, this is another unknown fact for most folks, that radiation doesn't reduce new primaries. You have that lumpectomy in that breast for DCIS, you give radiation. Doctors tend to think that's going to reduce new primaries in that breast. We know for a fact that doesn't happen. That's from the old NSABP B06 study. But it does reduce in quadrant, it does reduce recurrences of that index lesion. So it appears that radiation is reducing recurrence of the actual lesion, and mostly in radiated patients, endocrine treatment is just reducing new primaries. But again, there's that special class for elevated risk, you'd want to give radiation, but if you don't, for some reason or another, then endocrine treatment does seem to have a benefit in that group. Now, I have to say, all the numbers that we have in this study, you start with very large numbers, but when you start teasing these things out, it gets smaller. So these are really hypothesis-generating findings, and I hope you'll get to have a look at them.